Hello to everyone. Hope all of you are safe. And thanks to the scientific committee for inviting me to this meeting in a virtual way. And I will address during my presentation the management of the unfit and frail patients with myeloma. And the specific question I have to address here is if monoclonal antibodies should be used upfront or later in this patient population. Here you can see my conflict of interest. And in principle, the answer to this question, should antibody be used upfront or later in unfit and frail myeloma patients, is yes. And I consider monoclonal antibodies should be used in the upfront setting, even in this population. And of course, during my presentation, I will try to explain the rationale for this answer. What is the optimal sequencing of therapy in myeloma? The landscape of treatment for myeloma is quite challenging right now, but we know we have to try to utilize always the best, the first. This is an observational study conducted in Europe some years ago, putting together over 5,000 patients with multiple myeloma. And we observed how 100% of patients started at the first line of therapy, and we were losing 30% of patients between the first and the second and the third line of therapy and subsequent one. So the message is, do not reserve drugs for subsequent lines of therapy because patients might not arrive there. And if we consider this background, the optimal question would be, is this concept applicable to unfit and frail patients with multiple myeloma? In the same study, you can see right now in the right part of the slide how the performance status of the patients evolved through the different lines of therapy when they had to finalize or stop therapy after each line of therapy. And basically, the poor performance status was present in only 1% of the patients after the end of the first line of therapy, and increased up to over 10% of patients who had to discontinue therapy at the end of fourth or fifth line of therapy. So the number of patients that finalized treatment because of poor performance status increased over the lines of therapy, putting in context that we have to try to utilize always the best, the first. Is performance status an indicator for measurement of frailty? Maybe not only, but we know that elderly myeloma patients are a heterogeneous group of patients. And basically, in this slide, you can see different patients in which just looking their faces, it is possible to identify very fit, moderately fit, vulnerable, or severely frail patients. But definitely, maybe the first important question in order to afford the question if we can utilize antibodies in the upfront of this unfit and frail myeloma patient is who myeloma patients are fit and unfit or frail, and is it easy to identify them? This is a paper, a frailty position paper of the European Myeloma Network, in which they establish two conceptual models of frailty phenotype linked to sarcopenia, and frailty index linked to disabilities and comorbidities. And these two conceptual models of frailty are applicable to the general population. In the right part of the slide, you can see how multiple myeloma can impact in accelerating age-related physiological decompensation. And together with the DNA damage, with the senescent phenotype in the immune cells, as well as the metabolic disease, infections, cardiovascular diseases, we are going to see in this elderly population when they are becoming elderly, if we incorporate the disease multiple myeloma, we are definitely to accelerate this frailty process. You know that there are many different geriatric scales in order to identify which patients are fit, which patients are unfit, which patients are frail. And basically, almost all of them are including the chronological age within the factors to evaluate the frailty score. And they basically also include the comorbidities as well as the activity daily living, the instrumental activity daily living activities. And I would say that in a formal or an informal way, we have to try to identify which patients are fit and which patients are unfit and frail. But it's also true that to date, there is not any consensus for the identification of fit and unfit frail patients. And each cooperative group, each hospital, each country is utilizing their specific geriatric scales. This is an example of how in a large randomized clinical trial conducted in the elderly population, the first trial in which continuous therapy with lenalidomide and dexamethasone was compared with Lendex 18 cycles or melphalan-prednisone and thalidomide, a simplified frailty scale evaluated in a retrospective way was able to predict outcomes in this population. This modified frailty score basically considered the chronological age, the Charlson Comorbidity Index, and the performance status. And this model was able to distinguish between two different subgroups of patients, non-frail and frail patients. From the baseline characteristics point of view, we can see how in the frail subgroup of patients, patients were basically older, poor performance status, more advanced stage of the disease, higher levels of LDH, and even more patients with some degree of renal impairment. And for me, it's surprising, but it's good to see how, in spite of the fact that these patients were selected for being included in a clinical trial, and of course had to meet all inclusion criteria, 790 out of 1,618 patients, approximately 50% of patients were qualified as frail patients. And in this study, PFS and OS were different in the frail and in the non-frail population. And frail patients had a worse outcome than fit, although continuous Lendex was always better than Lendex 18 or melphalan-prednisone plus thalidomide. For me, this puts in context how this simplified frailty scale can be retrospectively utilized in the clinical trials that are currently ongoing in order to know the outcome according to the frailty. And I will utilize indirect evidence to justify my answer because as there is not much evidence about the use of monoclonal antibodies or basically treatments in unfit and frail patients, I will utilize indirect evidence. But before, which monoclonal antibodies we can potentially utilize in multiple myeloma in order to address the question specifically in unfit and frail patients with newly diagnosed multiple myeloma. Anti-CD38 monoclonal antibodies are already standard of care and taking part of our routine. BCMA targeted therapy is coming, but not in the upfront setting yet. And checkpoint inhibitors were abandoned in the upfront setting in the elderly population in combination with lenalidomide and dexamethasone. Other monoclonal antibodies are coming, but I have to justify the answer to my question basically on the role of anti-CD38 monoclonal antibodies. Daratumumab and isatuximab are the two anti-CD38 monoclonal antibodies approved so far for the treatment of patients with multiple myeloma. And both target CD38 expressed on the surface of the plasma cells with a direct anti-tumor effect. And both monoclonal antibodies have also an immunomodulatory effect that can contribute to maintain the response and to enhance the immune system, what can be interesting in the management of unfit and frail population, in which the immune system is going to be depressed not only by the myeloma, but also by the chronological age. In fact, we have a specific clinical trial conducted with a monoclonal antibody, daratumumab, in combination with ixazomib and low-dose dexamethasone in unfit and frail newly diagnosed myeloma patients. This study identified the unfit and frail newly diagnosed myeloma patients according to the IMWG frailty index, and patients received 9 cycles of 4 weeks of duration, including ixazomib, daratumumab, and low-dose dexamethasone, followed by a maintenance phase, receiving cycles of 8 weeks of duration, including ixazomib, daratumumab once per month, as well as dexamethasone at a very low dose, 10 milligrams. Important to note that antibiotic antiviral prophylaxis, as well as vaccinations according to the local policy, were rules clearly established in the trial, because this trial, as I previously said, was specifically conducted in unfit and frail newly diagnosed myeloma patients. The median follow-up at the moment of presentation of this study was 1.5 years, and the median progression-free survival was of approximately 2 years for the unfit patients and 1 year for the frail patient population. What is quite interesting and not short enough, indicating that this combination is attractive for unfit and frail patients from the progression-free survival point of view, but the same from the overall survival estimation. And in fact, from my point of view, the overall survival curves are quite good for unfit and frail newly diagnosed myeloma patients. But one important data to evaluate in this population is the safety profile. In the left part of the slide, you can see the hematological and the non-hematological toxicity, grade 3 and 4, reported with this combination in this population. And tolerability was quite acceptable, with no many hematological or non-hematological adverse events. And it's important for me to evaluate in these trials, specifically conducted in this unfit and frail population, the early death rate. These deaths occurring within the first 3 months after registration in the clinical trial, and overall was 7%. Only 2% in the unfit population, 12% in the frail population. And this is relevant because we know that the early mortality rate is something relevant even in other studies not specifically conducted in this population. This is the only trial with the results of a monoclonal antibody, daratumumab, in unfit and frail patients with positive results. Although it's important to recognize that it is a single-arm study. There is not any comparator arm. In fact, there is not any standard of care for the unfit and frail myeloma patients, and we usually utilize the standard of care for the transplant-ineligible newly diagnosed myeloma patients. And it's true that all patients included in this study, although they qualified for the unfit and frail definition according to the International Myeloma Working Group Frailty Index, patients had to meet some inclusion and exclusion criteria. So we have always to refer to unfit and frail patients in clinical trials. We have indirect evidence about the use of monoclonal antibodies in this population. One is based on the Alcyone study, phase 3 randomized study conducted in transplant-ineligible newly diagnosed myeloma patients, in which VMP 9 cycles was compared with the Dara VMP 9 cycles, followed by daratumumab single agent until progressive disease. And this is the progression-free survival in the intent to treat patient population, clear benefit of the addition of the monoclonal antibody in the intent to treat patient population, with also benefit in terms of overall survival. From the efficacy point of view, Almost all patients responded to this combination, 91%, with almost 50% of complete response rate. And even 1 out of 3 patients receiving this combination achieved undetectable measurable residual disease, what translated into a better prognostic in terms of progression-free survival. And even sustained minimal residual disease negativity was also evaluated, being able to identify a subgroup of patients with excellent outcome. But what I would like to show you here is a sub-analysis evaluated a simplified frailty scale in this Alcyone study, utilizing the same model I previously described you for the first trial: chronological age, Charlson Comorbidity Index, and performance status. When we differentiate frail and non-frail patients in the Alcyone study, we see the same phenomenon. More elderly patients were frail, as well as with the more advanced stage of the disease, poorer performance status, and more patients with some degree of renal impairment. And in spite of the fact that patients were selected for a clinical trial, approximately again 47% of the patients qualified for frail. How was the outcome of these unfit and frail patients in the Alcyone study receiving daratumumab in combination with VMP? You can see how DVMP was always superior to the standard of care VMP. And in fact, the median PFS for DVMP in fit patients has not been reached yet, 40 months for intermediate patients and almost 3 years for the frail population, indicating that these data, from my point of view, are quite exciting for the unfit and frail population, especially because if we evaluate also the safety profile, there are not major differences with the non-frail population. A slightly higher frequency of neutropenia, as well as a slightly higher frequency of pneumonia, but honestly no significant differences, and this data indicate that the monoclonal antibody is well tolerated even by the frail population. The MAIA is another trial conducted in transplant-ineligible myeloma patients, including the monoclonal antibody daratumumab in combination with Lendex. And this study was also positive in terms of progression-free survival. We don't have any specific sub-analysis based on the frailty score, and the only data I can show you is that 43.5% of patients were older than 75 years, what can be an indicator of frailty in this study. This is the median PFS on the intent to treat patient population, and when we evaluated the benefit of DRD across the different subgroup of patients, we can see how patients older than 75 years had maintained the significant benefit for DRD in comparison with lenalidomide and dexamethasone, indicating that maybe this combination can be also utilized in unfit and frail population. The response rate, as well as the complete response rate, was also higher for DRD, and this is something that will be maintained also in the unfit and frail population. From the safety point of view, the addition of daratumumab to Lendex in the intent to treat patient population resulted in more neutropenia and more infections. And if we evaluated the median relative dose intensity, for Dara was 98.4%, indicating that almost all patients were able to continue with the daratumumab, and more patients in the DRD arm had to reduce lenalidomide as well as dexamethasone. So maybe in the unfit and frail population, this combination could be utilized, doing some modifications for lenalidomide and dexamethasone, maybe in the long-term follow-up. In summary, I would say that Dara plus ixazomib and dexamethasone showed to be feasible in unfit and frail patients. Dara VMP can be used in unfit and frail newly diagnosed myeloma patients, and Dara Lendex could be also maybe used, although it's true that the sub-analysis is pending. But it's true that all patients, frail and unfrail, were included in clinical trials meeting the eligibility criteria. What about PI-CMIDs plus monoclonal antibodies, VRD plus isatuximab, VRD plus daratumumab? I decided to put here a question mark. because these studies are being conducted in newly diagnosed myeloma patients in which transplant is not planned, but not specifically in transplant-ineligible population. We have just some preliminary data coming from VRD plus isatuximab in transplant-ineligible myeloma patients with encouraging results, but more mature results are definitely pending. What about other monoclonal antibodies? Ilotuzumab has been combined with Lendex, but the trial did not meet its primary endpoint. And BCMA-targeted therapies through antibody-drug conjugated and T-cell engagers are coming and will be investigated in the elderly population, including unfit and frail population. Finally, in summary, the answer to the question, should monoclonal antibodies be used upfront or later in unfit and frail myeloma patients? My answer is yes, and monoclonal antibodies should be used in the upfront setting, even in this specific population. Today, we have to restrict the answer to this question to anti-CD38 monoclonal antibodies and specifically daratumumab, because some unfit and frail patients will receive just one prior line of therapy, so we have to utilize the best at the first. It is not valid to reserve monoclonal antibodies at relapse, and I have previously said how daratumumab has been evaluated in some clinical trials, showing its effectiveness as well as its good safety profile in unfit and frail myeloma patients, but definitely I think that the real-world evidence data will confirm all these conclusions. I stop here. Thank you very much for your attention.